I'm delighted to have her as one of our speakers because she got her doctorate at the University of North Carolina at Chapel Hill. And she did that in our clinical psychology program. And she did that working with me. Since she became Dr. Van Meter, she's been incredibly productive. She's written dozens of papers that have already been cited hundreds of times. She's won multiple early career awards from the Association for Psychological Science and the American Psychological Association. And her work is supported by funding from a variety of foundations, as well as the National Institute for Mental Health. She does extremely groundbreaking work looking at social media and ways that it might actually be able to be twisted to be a force for good instead of adding more stress. The talk is being recorded, and as we did with the last talk, we will put it up on YouTube, so it will continue to be available. And those of you who are tuning in live tonight, thank you for coming despite the roller coaster that has been this week. And for everyone else who is tuning in on YouTube, remember November 2020. It was wild. So on that note, it is my pleasure to give the podium, the virtual podium, to Dr. Anna Van Meter.
All right, thank you very much, Eric, and thanks to HGAPS for having me as a speaker. I'm really honored and excited to talk with you, and HGAPS is an organization that I'm proud to be involved with and really support what they're doing. So it's extra cool to be a speaker in their series. So as Eric said, the theme of my talk is to sort of explore a little bit how we might be able to use technology to help young people who are experiencing mental health concerns. And part of the reason that I think that this is an important topic is that mental health concerns are a big problem, particularly in the United States. So just to sort of set the frame a little bit, we know from multiple studies, both clinical studies and epidemiological studies, that about 20%, or some studies report even closer to a third of adolescents meet criteria for a mental health disorder. And it's interesting that we see similar rates in adolescence and adulthood. And the reason for that is that a lot of the more serious mental illnesses that persist, that have sort of a chronic course, have their onset in adolescence. So people who are developing mental health disorders during this time will often be affected into adulthood. We also have seen over the past decade or so that the rate of mental health disorders is increasing over time. The data that are here on the slide are from just this past year from the Mental Health in America survey. And what they found was that just in 2020, 10% more youth, adolescents screened positive for mental health problems in 2020 than in 2019. And that almost 100,000 more youth met criteria for a major depressive episode. And concerningly, we also see that among youth of color, the rates are going up more quickly. So we see this overall prevalence of mental health disorders is high and increasing over time. So the consequences of a mental health disorder can be myriad. There are the symptoms of the actual disorder, of course, but then there are many other things that are more probable because somebody has a mental health disorder. Perhaps most consequential is suicide. We know that the rates of suicide have also been going up among adolescents and young adults and even children, and that it's currently the second cause of death among people ages 10 to 24. People who have mental health disorders are also likely to have lower academic achievement, which has implications for their future. They may be less likely to do well in college, to be able to participate in things that sort of set them up for a good professional life later on. We also know that young people who experience mental health disorders are more likely to be withdrawn socially, and so they don't benefit as much from a strong social network. They don't sort of make the ties that many of us enjoy in adulthood, of these sort of early friendships. All of these things contribute to an overall worse quality of life, and this can be exacerbated by the fact that once you meet criteria for one mental health disorder, you're more likely to meet criteria for another mental health disorder. So these comorbid disorders can sort of expand, increasing the burden to you and ultimately to society. When people become adults, they may not be able to achieve the same level of employment. They may need more social services and things like that. One of the reasons that so many of these consequences of mental health disorders occur is that a majority of young people who meet criteria for a mental health disorder don't actually get diagnosed. And sometimes even when they do get diagnosed, they don't get the treatment that they need. So this graphic here is also from the Mental Health in America survey. And I think the figures that they're reporting here are pretty stark. That 60% of youth with depression don't receive any mental health treatment at all. And even among those who have really severe treatment or severe depression rather, only about a quarter of them receive consistent care. And part of this is an access problem. I'll talk a little bit more about how having access to mental health care is a real challenge. But even in areas where they reasonably should be able to get an appointment with a mental health treatment provider, in many cases they don't. Some will receive treatment, but it may not be the optimal treatment or what the treatment guidelines would recommend. And for those of us who do treatment research, I think this is particularly sad because a lot of effort goes into figuring out what are the best treatments, what is going to be most efficacious, most effective in treating mental health disorders in different ages and populations. So we know what can help, and we have a lot of really good treatments available, but a majority of youth aren't able to benefit from that. And I forgot to say it at the beginning, but I'll say it now, that if you have a question or a comment, I'd love this to be more of a discussion than me just talking at you. So please feel free to just say your question, or you can put it in the chat. And Eric has kindly volunteered to help moderate that, since I can't see the chat right now, but I'm really happy to answer questions sort of as we go.
These are very sobering numbers, and I'm really impressed with how much new data you're putting in with I hadn't seen the 2020.
Yeah, unfortunately, the newer data look worse and worse over time. I was at a talk by David Brent, who is a researcher from Pittsburgh. He studies depression and suicide in youth, and he showed figures showing the trajectory of suicide over time, and was saying how for him, he's much more advanced in his career. It was really sobering to look at this graphic and see the increase in suicide prevalence, even though he and, you know, a lot of people have been focused on trying to prevent suicide. So I think for those of us who want to reduce the prevalence of mental health disorders and, you know, create better access to care, this is kind of a wake-up call, and hopefully motivates us to do better, do more.
Do the newer numbers do they reflect COVID?
Yeah. That's one of, if you look at the mental health survey, that's one of the main things that they attribute this increase to is COVID. So we'll probably be like a little, you know, from the steady increase will be more of a straight up line. Yeah, exactly. So I mentioned that many of the young people who would meet criteria for a mental health disorder don't actually get diagnosed, and without a diagnosis, it's much less likely that they would receive treatment. And there are a lot of, you know, individual reasons that that can happen, but there are also some sort of general reasons that are often implicated in people not getting a diagnosis, or maybe not getting the right diagnosis. So one of these is the fact that many of the symptoms of mental health disorders, particularly in young people, are kind of nonspecific. So for example, a lot of the childhood disorders will present with irritability or distractibility or trouble sleeping. And so when you see this sort of constellation of symptoms, you can know usually that something is wrong, but you wouldn't necessarily know what the most appropriate diagnosis is without, you know, more specific assessments, which I'll talk a little bit about. Another thing that happens a lot is parents or maybe the adolescent themselves might not really know when a symptom that they're experiencing is something to be concerned about. So, you know, everyone knows that adolescents can be moody, they can be difficult, irritable sometimes. And so parents who may only have experience really with one kid or a couple of kids don't necessarily know when something is really cause for concern or not. Another issue that comes up is that many of the disorders, particularly mood disorders, which is a specific research interest of mine, are episodic. So things change over time, and depending on when somebody might come for treatment or for an assessment, what you see could be different. And people don't always do a great job of remembering what things were like in the past, but that information can be really important to making an accurate diagnosis. Or they may remember things slightly different than what was actually happening, or the clinician working with them might not ask a lot of questions about the past, which brings us to the next obstacle, clinician biases. So when somebody comes to your office and they might say, "Oh, doctor, I've been feeling so depressed," or "My child's been feeling so depressed. What can you do to help us with this depression?" It would be pretty easy to say like, "Oh, what symptoms of depression are you experiencing? Let's talk about how I can help you with your depression," without really thinking about what else might be going on. Are there other disorders like bipolar disorder, for example, where somebody might be experiencing depressed mood but don't actually have depression? And so if we sort of hone in on what we think the diagnosis is right away, we may miss out on the fuller picture and end up giving the wrong diagnosis, or maybe diagnosing one disorder accurately but missing other things that are going on.
I had a question about like biases when coming like clinician biases. Is there like for instance, not just the biases that come from like maybe the symptoms that might being shown, but when it comes to like their race or their gender, because I know that, you know, there's such a thing as like risk analysis and how that could influence like what diagnosis you go with based on their demographics. But when does it cross the fine line between like relying on like racial stereotypes and um
Culturally informed assessment.
yeah, okay.
Yeah, I think that's a great question. And I think that there are some disorders where we see clear differences in prevalence based, you know, particularly on gender is what I'm thinking about. So like autism spectrum disorders are much more common in males than females. ADHD is somewhat more common. But I think ADHD is actually a good example because the prevalence in boys is around 5%, and there's sort of a question about the prevalence in girls.
Yeah, because it presents differently sometimes.
Right, exactly. So the symptoms might be somewhat different and maybe a little bit less stereotypical. So you might be less likely to see a lot of acting out or hyperactivity. And so I think, you know, that's a good example of how some of these biases and thinking, you know, when I think of ADHD, I'm looking for a boy, could lead to a girl not getting that diagnosis, even though she would, you know, benefit from treatment. I think in terms of race and ethnicity, there's less evidence to suggest that there are differences in prevalence, particularly when you think about youth who are living in the same culture, like in America, for example. We do sometimes see, or there's some evidence at least for differences in different countries based on, you know, maybe diet and other environmental factors. But there is good evidence to show that there are clinical biases in the rates of these disorders clinically, depending on the race of the child. So that's definitely very concerning because some racial ethnic groups might be getting overdiagnosed or getting the wrong treatment based on these biases. Good question, Emma. Luckily, there are some tools that can help us clinicians to kind of overcome these biases. And I could say a lot about evidence-based assessment, but I'll just sort of briefly summarize what an evidence-based approach to assessment would entail and how that can help somewhat with the types of biases that I've described. So in, let's say, a non-evidence-based approach, what might happen could be similar to what I described earlier, where, you know, a family or an adolescent might come to you and express a particular problem that they're experiencing. And as a clinician, you're eager to help them, so you focus on that problem, maybe to the exclusion of other things, and you sort of think about how you want to treat it, and you're off. In an evidence-based approach to assessment, there's a bit more of a systematic approach. So for example, we would recommend that you start with a broad screening tool. A symptom measure that's going to ask about a lot of different domains, not just the particular domain that the family is coming in to talk about. And this helps you get a sense for what might the main problem areas be. And there could be things going on that aren't sort of the primary pain point that brought them in, but that also deserve attention. And based on the results of that broad assessment, you can then do more specific assessments. So if it seems like mood problems are prominent, you might choose a depression measure or a mania measure to see if you can get more specific information about these particular domains. And then you would use that information to inform a structured interview that you would do, where you would ask questions that really go through all of the DSM criteria for a particular diagnosis that you've identified as sort of a likely candidate based on the earlier assessment that you've done. And it might sound like this would be sort of a time-consuming process compared to, you know, the less evidence-based approach. But I think even if it might take slightly longer, say you send the family a link to some assessments, perhaps in the HCAHPS Assessment Center, and have them complete those before your session, then you haven't really spent any of your time. And within the session, you can really focus on the most important domains. And ultimately, you probably save time because the treatment plan that you're going to develop in collaboration with the family is going to be more targeted. It's going to be better for sort of the full scope of problems that they're experiencing. Whereas with the other approach, you can end up in sort of like a whack-a-mole situation where you didn't fully define the problem to start with, and each week it can seem like there's a different thing that needs to be addressed, and treatment can go on longer and be less effective than if you take the time at the beginning to really suss things out and figure out the best approach.
That's if they keep coming.
But I think that the patients might have believe that the clinician has a higher level of competency and maybe trust them more if they do go through all the assessment, maybe, and maybe that'll be, you know, make them more likely to come back because they're being so thorough. I don't know.
I agree with you. And I think there is research actually to show that as well, that families like it when they feel like you've really gone to the effort to fully understand them. There's research showing that just doing those assessments can be a form of intervention because families might start to learn something about themselves, and they also might feel more hopeful just because they're like, oh, you know, somebody is really learning about us, somebody is going to help us with this. And I think to Eric's point, if you're taking this sort of whack-a-mole approach and haven't really thought through the course of treatment, or maybe you haven't selected the treatment that has the best evidence base for the disorder that the person is experiencing, they're not likely to get better quickly, and they can quickly decide coming here every week is really a pain and we're not seeing an improvement, so I think we're going to stop. So you definitely can't help them at all if they're not there. So I think that's a really good point too. One thing that we know is that taking this more evidence-based approach really significantly improves the accuracy of the diagnoses made. So this illustration here shows us a little bit about the accuracy of what might be a typical clinical diagnosis, kind of a free-form interview. And the way that you read this is sort of the trade-off of the sensitivity and the specificity of a certain approach, and how well how efficiently it identifies people who meet the criteria of what you're interested in. And the line here, the diagonal, is 50%. So that basically means you could interview the family and talk to them about their concerns, or you could just flip a coin, like either one would sort of get you to the same spot. And you can see that the clinical diagnosis is really just slightly better than chance.
Ouch.
Indeed. If you take a structured interview, like the case ads, for example, or if you work with adults, you might use the SCID. It has many modules. You go through all of them, ask a lot of questions, then you can significantly improve the accuracy. So you're getting close to the corner up here, which would be sort of 100% accurate. But, you know, that may be too time consuming depending on the type of setting where you work. But just adding one of those checklists that I talked about can get you more than halfway there, and, you know, could take just a few minutes, really. So I think this is a pretty powerful illustration of, you know, the significant benefit that you can achieve from doing even part of this evidence-based approach versus the more free-form clinical interview. There have also been efforts to see whether we can get, you know, even closer to 100% accuracy using more sort of sophisticated algorithms to take the information that we get from the patient and from the family and combine it in a way that will really tell us with certainty not only what might be going on with them right now, but also sort of predicting into the future what diagnosis they might meet criteria for further down the line. So Eric and others have used machine learning, which is a really advanced statistical method to take these different pieces of information and combine them in different ways to try to figure out sort of what the optimal algorithm is. And what we find in this type of research is that you can get a really precise algorithm for the sample that the data come from that you're using. But when you try to use the algorithm in a new sample, it often doesn't work very well at all. And a way around this is to build a classifier based only on symptoms. So sort of ignoring other characteristics of the youth, because this is the hallmark of the disorder. So if we just focus on the symptoms of the disorder, but you don't necessarily need a fancy algorithm to assess just the symptoms. There's also been some research looking at risk calculators, which is sort of a similar idea, but like I said, more predicting into the future what type of diagnosis somebody might have later on. And again, you know, if you use different sample characteristics, you can get a really precise prediction, but only in the sample where you originally built the algorithm. When you try to use it elsewhere, it kind of falls apart. So in research that Eric and I and others did with this, we found again that using just the symptoms of the disorder, even before somebody meets full diagnostic criteria, was the best way of predicting what's going to happen in the future. So if we think about other fields where they make predictions, the one that comes to mind for me is the weather, right? So we're always thinking about predicting the weather, what's going to happen in the future, what's the weekend going to be like, etc. And when we're predicting or forecasting the weather, not me personally, but meteorologists, they have a lot of different types of data that they can use. So they have really sophisticated machines that collect information about humidity, about air pressure, about wind speed, all of these different things. And they can put those together and understand, you know, how long is it going to take the storm to get here? Once it gets here, how much rain is there going to be, etc. And I think you know, that's something that we would aspire to and would like to be able to do, particularly for young people, to be able to figure out, you know, when is that storm of depression going to arrive? What might we be able to do to prevent that? But the fact is that, you know, in our field, we rely so much just on symptoms. And so we can say, you know, if it's raining right now, it's more likely to be raining an hour from now than if it's not raining right now. So we rely so much on the symptom of the disorder to tell us we don't have these other kind of inputs necessarily. So when I started thinking more about this and this limitation that we're up against, I got interested in other ways of collecting information about people's mental health that doesn't rely on them just to tell you how they're feeling. You know, as I mentioned, people have different ways of describing what's going on with them, or different perspectives on how serious it is or what happened in the past. So if we can sort of take some of the self-report out of it, we might be able to improve our ability to make diagnoses or to make predictions in the future. So some of the information that I learned about come from different types of technology to sort of monitor how people are doing. So for example, in this study, they were looking at mobility and how people who are more depressed tend to be less mobile. They go fewer places, they stay home a lot more. And it makes sense, but it's just sort of a cool way of monitoring that, rather than just asking somebody, do you stay home or not? You can kind of see their mobility patterns and learn something about that. In these studies from Melvin McInnes, they've done really interesting studies where they talk to people on the phone month to month, and they can tell the mood state of somebody who has bipolar disorder just by the quality of their voice in these phone calls, which, you know, probably isn't something that in a lot of cases we would necessarily pick up on just talking to somebody, unless they're, you know, really manic. You might be able to tell that. But it's information that we can easily collect just in terms of voice samples, and could be something that we would add along with other self-reported information to try to help us improve our diagnoses.
Isn't that why the PHQ-9 asks, have you been talking so slow that it's like that other people have been able to notice, or something like that?
Yeah, so kind of being slowed down is definitely a symptom of depression.
Yeah.
But I don't know, an individual may or may not be aware of that if no one else commented on it.
I think that's why the PHQ-9 says, like, have other people commented on if you've been talking slower than usual or something. But to your point, if they're not going out and they're not socializing, then who would be around to even notice that?
Yep, exactly. But if we could record them talking, then we can get some of that information even without the collateral report. This study similarly was looking at geographic data, so where people went, and diagnosing bipolar depression based on that. And then using another type of technology, an actigraph, Kathleen Merrick-Hengis has done some studies looking at how people with bipolar disorder are different from other adults with mood and anxiety disorders, just based on their sort of daily activity of their physical activity. And I was fortunate to be able to do a sabbatical with Dr. Merrick-Hengis a few years ago now. And learn more about this method of using actigraphy, and sort of got interested in how this could be sort of an unobtrusive way of getting information about a number of different domains of behavior that are relevant to mental health. So along with help from Emma and Lizzie and Logan, we collected data from UNC students to see whether we could classify students who had a history of mood disorder based on their daily patterns of moods, so how they felt day to day, how they slept, and their physical activity. And then we also wanted to see whether these patterns helped us to predict who was more likely to experience mental health problems later on in college. It's a pretty well documented phenomenon that many people experience declining mental health early in college, particularly. People are often away from their families, away from their social networks. They might feel a lot more academic pressure, they have less structure. So there can be sort of a perfect storm of factors that contribute to declining mental health. So to do this particular study, we recruited students. We did a pretty long survey to get information about their pre-existing risk, their mental health history, and so forth. And then we did 7 days of intensive data collection using this Gene Active, which is an actigraph watch. I usually describe it as like a Fitbit on steroids. So it's just a research quality Fitbit. And then we had them fill out these daily surveys about their sleep and their activity and other things like that. And then we did an outcome assessment a couple of months later to sort of see where things went for them. Just to give you an example of the type of data that you can get from the actigraph, this is just a couple of samples from some of the participants. So the red line is when the watch thinks that you're sleeping. Basically, you're not moving around, and particularly when there's no yellow, that means you're not moving around and it's dark. So that's a high probability of sleep, particularly if there's like a little bit of movement, because that indicates you probably didn't just take the watch off and put it in a drawer or something. But for this particular person, you can see that they were very active from about 6 p.m. to midnight or 1 a.m. But then they were sleeping a lot, you know, sort of over the nighttime hours, but then a lot also in the daytime. And that might be consistent with somebody who has hypersomnia, they're sleeping too much, they're, you know, presumably not going places and might be depressed. In contrast, this other person is getting up at 6, you know, very active, then maybe taking a nap around 4 o'clock, and then up until 2. So they're only sleeping, you know, 4 hours. And this could be somebody who might be doing a lot of schoolwork and cramming, or it could be somebody who is manic and has decreased need for sleep. So this is the type of data that we can get from the Gene Active. And I've only done some sort of preliminary analyses with the data from this study, but one of the things that we see is that people who report a diagnosis of mood disorder have poorer sleep quality. And among all of the participants who had poor sleep quality, we see that on some of our self-report measures, they're more likely to have emotion regulation deficits, symptoms of depression. They report higher stress and anxiety as well. So we can see that people who aren't sleeping well also are at risk for mental health problems based on their symptoms and kind of psychosocial functioning. So this study, was interesting, and I'm hoping to do more with the data. But another thing that kind of came from it is that people weren't that wild about wearing the gene active. So that's sort of a limitation. And actually, when I was kind of figuring out this study for quite a while, I wore one of these myself, and one of the students who was in my lab at the time was like, oh, I wondered why you were wearing that, because normally you dress well, but it was just so ugly. I couldn't understand why you would wear it. And if you want people to wear this sort of all of the time and not just for a week, that becomes a problem. And, my particular interest is really in adolescents and young adults. And there's been some research about their willingness to wear this type of thing. And in general, we see that people who have a Fitbit or something like that, so one that you would purchase yourself, not a research one that looks much worse, about half of people stop wearing them within 2 weeks, and 80% of people stop wearing them within 2 months. And then if we sort of see among adolescents specifically what types of technology they use, a large majority of them go online looking for health information. About 20% use apps about health or play games, but only about 7% report wearing any device like this. And I thought that this quote from this study summed it up really nicely. This girl said, "I got the Fitbit for Christmas and wore it for a while, and the bracelet fit my wrist weird and hurt. I was like, forget it. And then I stopped using it. Also, it's not cute, and it's just kind of weird, and mostly males use it. All my friends' dads have it, and I'm like, thank God I don't wear that anymore."
You don't want to look like a dad.
Exactly. Once your friends' dads have it, it's definitely not cool anymore. So this is kind of a significant obstacle. And I had a couple of years ago been pretty far down a path of designing a study using Fitbits for adolescents when I started looking more into this, and I decided not to do it just because for the cost and everything associated with this, to have people wear it for a couple of weeks or whatever didn't seem worthwhile. In contrast to a Fitbit, one thing that adolescents do like a lot are their smartphones. So we know from a study by the Pew Research Center that about 95% of adolescents have a smartphone. And another factor that's really important, particularly for research, or if you wanted to use this for clinical use, the rates of smartphone ownership are pretty much the same regardless of the person's demographics. So we don't see big differences in ownership depending on their race or their socioeconomic status. So if you design something that relies on a smartphone, you can be pretty sure that a vast majority of adolescents are going to be able to do it, which is really important. There has, however, been a lot of negative attention paid to the fact that adolescents are, at least stereotypically, constantly attached to their smartphones. So I mentioned at the beginning of my talk that the rates of mental health disorders have been going up, and people have shown that this increased trajectory of mental health disorders coincides pretty well with the introduction of smartphones and social media. So in this study here by Jean Twenge, the dotted line shows increase in depression symptoms over time. The black line shows increase in screen activities in adolescents. And then the gray line shows a decline in non-screen activities. So like playing sports or doing other things that don't involve a phone or a laptop or whatever. And this correlation has gotten a lot of press, and it's been shown in multiple different data sets. This study is also from Twenge, showing that low well-being in data from both the US and the UK is associated with greater digital media use. So the more you use it, the more likely you are to report low well-being. But like a lot of things, I think the picture is a little bit more complicated than that. So in another study by Best and colleagues, they reported that there are actually quite a few benefits of using these online technologies for adolescents, including increased self-esteem, social support, social capital, and being able to experiment with identity and self-disclosure.
Are these correlative studies as well?
Yeah.
Okay. Because I was also just thinking if someone's like more depressed and doesn't really feel like going out, maybe they're using technology to distract themselves. Like there's ways in which they could reinforce each other, of course, but like also have different directions of influence.
Right. Yeah, exactly. And for some people, having that could be really positive if they don't feel well enough to go out, if they're able to get some social support or attention through social media or whatever, that could be a good thing. So I think it depends on the individual. It's not sort of the same pattern for everybody. These data are from Canada, the Ontario Student Drug Use and Health Survey. And so along the bottom, you have hours per day spent on social media. And then this is basically a metric of psychological distress. And what they found, which is interesting, is that there isn't really a dose response relationship, meaning it's not like the more hours you spend on social media, the more psychologically distressed you are. But also that over time, whatever association there might be has gotten weaker and weaker. So the data from 2013 show, somewhat of a more positive association. And then the most recent data from 2017, the line's getting flatter, meaning that there isn't really an association between these two things. In a study that I'm currently doing, we recruited about 300 young people between 14 and 22 just through social media. So we put like ads like this one to try to assess the impact of coronavirus, and more particularly the social distancing and stay-at-home orders, like what the impact of these policies would be on young people. So we've been following them since March, and we have 3 waves of data now kind of cleaned, and we just finished the 4th follow-up, but I haven't looked at the data yet. So I was interested in looking at these associations in these data, and what we have over here is their score on the PHQ-9, which is a depression measure, and then we have the different time points. And for this, I broke them into low screen time versus high screen time, just based on what the average screen time use was. And you can see that the people who reported higher screen time show slightly higher depression scores, but this isn't clinically meaningful. They pretty much overlap until you get to August, which is interesting. And the people who have lower screen time have had sort of a steady decline, probably as they're able to go out and be more active. You could speculate that this might have to do with school starting. I don't know. But there isn't a huge difference here between high and low screen time and how depressed they reported being.
And just to clarify, this screen time is only measuring like screen time on their phone and
Right.
and not and like screen time for like social media or apps and not like for Zoom classes or something like that.
Right. It's just their phone screen time. If they use their phone for Zoom, then that would be counted.
Okay.
And this is
We-
2020?
Yep.
Wow.
I should also say for people who aren't familiar with this measure, that a mild depression score would be from about 5 to 9. So people are reporting, elevated symptoms of depression, particularly in late March, and then, tend to improve. This graph shows something a little bit different. We have a measure in the study of what I'm referring to as sort of online belongingness. So the questions ask things like, true or false, people online understand me. True or false, I feel like I can be myself online. True or false, people online make life more difficult for me. So we kind of get an assessment for whether you're having a positive social experience online or not. And here we see that people who have low online belonging, so they're having more negative experiences, actually do have higher depression scores than people who are reporting more positive social experiences online. And then I looked at the interaction between how much time you're spending on your phone and then whether you have low or high belongingness online or in social media. So here is low social media belonging. Whoops. So if you're spending high screen time, but you also have low belongingness, you're going to have the highest symptoms of depression in this particular sample. Whereas people who have higher social media belonging, kind of regardless of their screen time, are reporting lower depressive symptoms. We also looked at anxiety scores, and it's a pretty similar picture here. So screen time, higher screen time is associated with slightly higher anxiety. But when you look at the belongingness, this is where you see more of a difference, where people who have low belongingness are reporting higher anxiety over all of the time periods. And then, this is a pretty dramatic interaction, I think, where people who have high social media belonging, kind of regardless of their screen time, are reporting lower anxiety relative to people who have low online belonging and are spending a lot of time there. So what I'm taking away from this is that people who are spending a lot of time online and having, on average, poorer experiences or more negative experiences are really impacted by that. But people who might be spending a lot of time online but feeling good about those experiences probably aren't having a negative consequence to their mental health from that.
And I'm sorry, I think I missed this, but how often were you giving them the PHQ-9 and the anxiety measure?
Just about every 2 months. So March, June, August, and then we're gonna have another one from October. But I haven't looked at the data yet. So hopefully we'll follow them for a year in total and see what happens.
And is your app iPhone and Android?
There's no app, it's just a survey.
What's tracking the screen time?
We asked them to go into their settings and look it up.
Huh.
So.
Eric, I know I don't know if an Android does that, but basically an iPhone every week will give you a screen time analysis and will break down the type of app that you used and how long you were spending hour-wise across that app. So that's what she's talking about.
Yeah, the Androids do it too. It's called like Daily Life or something like that. I can't remember exactly, but they both have it.